Start broadcast. Show your screen. And show screen.
Okay, we can hear that whispering. Whispering doesn't do any good.
Go ahead.
The broadcast is now starting. All attendees are in listen-only mode.
Hello and good morning from the West Coast and good afternoon on the East Coast. This is the National Wraparound Initiative's April 8th, 2014 webinar, Costs and Cost Effectiveness of Wraparound Programs. I'm John Osowski, the National Wraparound Initiative's Program Manager, and I'd just like to go over a few announcements before we begin today's discussion. First of all, this webinar is brought to you in partnership with the Technical Assistance Network, so our thanks goes out to those folks as well. Secondly, for best results, please check your settings in the audio pane if you're experiencing any audio problems. During the presentation, you can send questions to us via the webinar chat feature, but these questions will be held till the end. Please note that this webinar will be recorded and we will post it to our website within a few hours of the webinar's completion. You can see the direct URL on your screen right now to access that recording should you need to in the future. So while we're waiting for folks to join us, I'd like to introduce a little poll that will hopefully help inform our conversation today. I'll open the poll and then I will close it in about 1 minute, and thank you in advance for your participation. All right, everyone, we're still polling here. This is a poll that hopefully will inform our conversation today. So if you don't mind, please participating. We've got another maybe 30 seconds left of it. And we're ready to move on from our poll. So I just want to thank folks that did vote. We're going to close the poll now. Okay, and we'll share some results of that in a little bit. So at this point, I would like to, again, thank you for participating in the poll, and I'd like to introduce our speakers today. Bruce Camerad is the Administrator of the Children's Mental Health Services for Milwaukee County and Director of Wraparound Milwaukee, a unique system of care annually serving over 1,600 children with serious emotional and mental health needs and their families. Created as one of the first publicly operated managed care entities in the country and recipient of numerous prestigious recognitions, Wraparound Milwaukee pools over $50 million per year for Medicaid, mental health, child welfare, juvenile justice, and the school system to provide a comprehensive array of services and supports for families. So we'd like to welcome Bruce on today. Mr. Camerad is also a graduate of the University of Wisconsin-Milwaukee School of Social Work and has served as a consultant to many states and communities on systems of care design, development, and financing. He's written a number of articles, papers, and monographs on the Wraparound Milwaukee model. And also joining us today is Janet Walker. She is a Research Associate Professor with the School of Social Work and the Regional Research Institute at Portland State University. She is also the co-director of the National Wraparound Initiative and Research and Training Center on Pathways to Positive Futures. And with that, I would like to turn things over to Janet.
Well, thank you, John, and I'd like to welcome everyone today to the webinar, and welcome on behalf of the National Wraparound Initiative. And so let's take a quick look at the findings from the polls. Can you put that up, John?
Sure.
Okay, so I guess this is more or less what I might have expected, that we have more folks using Wraparound than not using Wraparound on the call. And we also have more folks who are unsure about the cost of care for taking care of children and families in their system of care than we do people who really feel like they have a good handle on costs. And that's true both in the Wraparound case and for those who are not using Wraparound. So I think that's very appropriate. Part of what we want to talk about today is not just about studies of cost, but in a kind of a pragmatic way. How can you collect data on cost and cost effectiveness? What have other people done? How can this be part of ongoing or a part of a use of your data that you may already collect, and how can you do this in a practical way in your system? So let's go on to the next slide, and we'll just go preview a little bit what we're going to be talking about today. So first of all, I'm going to talk just for a little bit about some overview of recently published research and evaluation on costs and cost effectiveness in Wraparound. And then we're going to turn the focus to Wraparound Milwaukee, and Bruce is going to talk about their evidence and also talk about how that information has been used to strengthen, sustain, and expand the program that they have there. Again, we're going to have questions at the end. You'll see in your little webinar control box there is a place that says questions, so you want to use that question box to text the questions to us, and we'll be answering those at the end. We anticipate maybe about an hour, maybe a bit more for the entire webinar, depending on how many questions they have and how long people want to hang around to have them answered. Okay, next slide, please. So we had a bunch of early cost studies. Most of these were completed prior to 2005, so about a decade old at this point or more, and they documented quite a bit of savings, both on the order of sort of thousands of dollars per child and sometimes millions of dollars per year to these different systems of care that were employing Wraparound. You can see Wraparound Milwaukee, one of the early programs, also represented there. So the question is, and we know that Wraparound in the early days and continues to be one of the goals, obviously, is to keep kids out of those expensive institutional placements and to keep them in their home communities and with their families. So the question is, as the whole system of care movement has matured in the United States, does that mean that those early cost savings would they represent sort of low-hanging fruit in terms of being able to keep kids out of those expensive placements? And in which case might the newer studies find a different result because perhaps those savings had already been reaped in those communities? So that's a question that we're going to examine somewhat today. We also have 4 newer studies, and I'll tell you how you can get a hold of documentation in the form of some kind of report on each of those studies available on the National Wraparound Initiative website, so you can find out more about them if you wish. So let's go to the next one. So this was the biggest of the 4 studies. Again, we see a very recent final evaluation report produced in 2012, including data that was gathered in 2012, so quite recent. And this is from the so-called PRTF, or the Psychiatric Residential Treatment Facility Waiver Demonstration Program. And this was a Medicaid demonstration program that allowed the state grantees to compare 2 ways of providing care for children who were enrolled in Medicaid. One was obviously the PRTF approach, which was the approach that was kind of standard for these particular young people at the time, and the option was to provide home and community-based services instead. The demonstration was authorized by Congress, and the idea was to demonstrate cost effectiveness, particularly, or in other words, good or better outcomes with equal or lower costs. So this program, again, it targets children and youth who would otherwise not have been eligible to receive intensive community-based services and instead of the treatment in the PRTF. And ultimately, there was participation from 9 states. 4,000 children and youth were enrolled in the demonstration waiver. And the evaluation was essentially a pre-post, so comparing how things were previously to how they were after things became different, in this case with the implementation of the waiver. The costs, and that was the pre-post, was for the outcomes, and the costs were also compared to what costs would have been in the absence of the waiver. So all 9 states, as you can see up there at the top bullet, used Wraparound in some form. And the report was quite clear that overall the children were indeed able to either maintain or improve their functioning while in the waiver program. And the states used both common measures and measures that were shared across all the states, as well as unique measures. So the report describes how they combined that data. But in the upshot was, this is a quote from the report, that most children showed improvements for most domains and most follow-up periods. There was also improvement in global functioning, and the mental health improvements were greatest for those with the highest level of need. Additionally, we have the cost information, pretty striking here. Waiver costs were 20% of the average per capita total Medicaid cost for services in institutions. So what they believe similar services, or what they believe the cost would have been for these young people to be treated in PRTFs. And the average per capita saving of $20,000 to $40,000. So the report is quite unequivocal that yes, it was cost effective, meeting that kind of criterion of being simultaneously providing as good or better outcomes with the same or lower costs. Okay, next one, please. So this study, again fairly recent, published in 2011, was in Massachusetts, and this was the cost portion of this study was quasi-experimental, in which the population that received Wraparound was matched to a control population, and they were matched in terms of having age, gender, community, psychiatric diagnosis, severity of impairment, and insurance type. Data was based again on Medicaid claims, and the procedure that was used was called propensity score matching, and the results that were compared for kids who received Wraparound versus those who were receiving usual care. And as you can see from the top set of bullets there, the intervention group was a lot cheaper. Primarily that was because of using lower intensity services, and so lower level of care. And they had substantially lower claims expense overall, was $811 per month. As you can see, that's almost $10,000 a year, which is substantial. And for example, that was mirrored in the decrease of 30% for emergency room costs and 74% lower for inpatient psychiatry. So the outcomes also, these were done in a pre-post approach, similar to other outcome studies that we'll see later on. And you can see here that these were, again, outcomes as far as where the costs were incurred. Hospital admissions were down, long-term residential care was down, acute residential, foster care also. So again, we can see pretty substantial cost savings here, and I would say evidence that is reasonably compelling, if not, it wasn't a randomized control type study, etc. So next study, this is on costs only. This is from Wraparound, Maine. Similar pre-post kind of approach, looking at, again, Maine Care Service claims, 148 children and youth. Again, pre-post analysis, looking at the 12 months prior to their enrollment in Wraparound versus the first 12 months in Wraparound. And again, here we have the bottom line, which is literally the bottom line on the figure here, shows 28% substantial, $16,500 worth of reduction in costs. between that pre-year and the first year in wraparound. And again, most of those declines, the biggest ones in terms of savings, were again inpatient hospital residential treatment. So next, and this is the last one we're going through pretty quickly here, is from my own state of Oregon, and this was from the demonstration of the Oregon statewide Children's Wraparound Initiative. Again, we have a report, pretty recent, 2012. This is data from 3 demonstration sites that were covering 8 counties here in Oregon, with about, again, substantial number, 550 children and families served at the time of the report, and it compared costs from these counties to costs in counties that were not participating in the demonstration. So the next slide just touches on the cost, the way that the costs were calculated. These are in the 3 years of the demonstration that were evaluated, so there's no pre-demonstration cost information here, but it compares the total billed per 1,000 members who were basically in the child population in the calendar year. And what you can see there is apparent impact of the wraparound in the wraparound counties, that they were able to kind of hold a lid on costs while the costs in the other counties continued to escalate. And as I said, we don't really know what happened in, for example, calendar year 2008, when there was no wraparound in any of those, well, no demonstration project of wraparound going on in any of those sites. So it's a little difficult to say what they might have looked like pre-intervention. But nevertheless, this is again, you know, pretty convincing cost data, and in fact it was reasonably convincing to our state because they expanded the demonstration project again as of now. There's also the next slide talks a little bit about some outcomes that were, again, this is sort of the pre-post at what was sort of a profile of the young people when they were coming in versus as they were leaving the program. Children not on psychotropic medications, that went up about 10% to 59% from 49. Living stability, again, no moves in prior 90 days, increased about 13% from 60 to 73. And then those the high moving population, that was decreased in their moves from 11% to 2%. And then the percentage of children living in family or long-term non-foster care increased substantially from 14 to 51%. Caregivers who felt that they were getting adequate to excellent support to address problematic behavior increased from 49% to 72%. So those are all outcomes that are pretty important to wraparound. And if we take all of these studies as a group, we're seeing again a kind of a similar pattern where there are definitely cost savings. The cost savings look like they're coming from primarily from those high-cost at-home placement situations, and correspondingly that kids are living, as far as the outcomes go, kids are living in less restrictive environments and in their home communities. And with a sort of on the whole, they seem to be doing reasonably well where the evidence shows as far as other outcomes as well. So basically that sounds a lot like the early cost studies. As far as the original question goes, it looks like we're still working on getting kids home. And obviously in a more, I'm eager to hear what Bruce has to say about efforts in Wraparound Milwaukee to keep them home. Because I know they've done a good job at keeping young people from ever going into these institutional placements. So just kind of FYI, there's some other recent cost studies. One in particular that will be released soon, and I've seen some highlights from this report from Nebraska demonstrating substantial savings. And if you are on the NWI listserv, you will know when that comes out. There's also a citation, and I've provided the citation down here because we don't have this posted on the NWI website, but this was from a 2012 webinar. This was at the Georgetown Institute's kind of the last time around, by the Director of Children's Behavioral Health in New Jersey, showing substantial savings, $40 million statewide, in acute inpatient services, residential treatment budget reduced, and length of stay in RTCs decreasing as well. Next, please. So again, for more information, I told you at the top I would let you know how you can find the reports that are associated with the information that I was talking about today. It's on the NWI website, which is there. If you pull down the tab on resources and look in the library, there's a tab for financing and then for costs. And of course, if you join the NWI, we'll let you know about any good news studies as they come out. So, and of course, we also have more information, very up-to-date cost information that we're going to hear from Bruce right now. And I'm very pleased and proud to introduce Bruce and to have him be a participant. And really, I would say Wraparound Milwaukee was sort of the model, I think, as far as having this good data on cost, being able to use it to leverage, to expand their program, and to provide sort of the ongoing evidence of, again, not just the effectiveness, but the sort of ability to deliver results while also saving money and enabling reinvestment in the community. So thanks very much. And Bruce, take it away.
Thanks, Janet. Pleased to be with everyone this afternoon to talk about costs and cost effectiveness. And I'm going to really spend the time looking at the cost effectiveness and some of the outcome studies we put together in Wraparound Milwaukee, which is now 18 years. We've been around 18 years, which is hard to believe. But I think the importance of the cost data, the fiscal data, is that it's been incredibly important to sustaining our project. It's been a key to the sustainability and tremendous expansion in enrollment and funding. Now this afternoon, as I talk about this, I'm going to really focus. I don't want people to think that program outcomes and clinical outcomes are not important, but we're going to really focus on, so I'm not going to focus on the clinical, on CBCL or CAN scores. I'm not going to focus on school attendance or academic performance, family satisfaction, fidelity. We're not really going to be looking at that. We're really going to be focusing very, very specifically more so on the cost part of it, because it's something that a lot of times I think programs don't focus as much on, or aren't able to figure out how to do it in a good manner. And so we'll talk about some of the things, and I hope my little prelude here to beginning is that you may not do everything or capture everything we do or in the same manner, but hopefully there's some lessons learned from what we do and how we go about showing fiscal outcomes. So, but being able to measure and demonstrate this has really been very important, and it's really allowed us to expand the program from the original 25 youth 18 years ago to now an average of 1,075 children on any given day and their families in Wraparound. So next slide. A little background, because I think it's critical to know that as we talk about how and what we focus on in cost data. But Milwaukee County is a county culturally, ethnically diverse, 1.1 million. In the mid-1990s, Milwaukee faced really significant clinical, programmatic, and fiscal issues related to how care was provided to children with serious emotional and mental health needs. There was an overutilization of institutional care, particularly, and it's very germane to what we'll be talking about today, in psychiatric inpatient hospitals, residential treatment centers, and juvenile correctional facilities. The high placement numbers of these youth by mental health, child welfare, and juvenile justice was really creating serious fiscal issues for Milwaukee County. And going to the next slide. And the clinical outcomes were poor, and recidivism was very high. The Planning Council of Milwaukee did a study, and recidivism rates showed that 60% of the youth that were deemed successful coming out of residential treatment centers were back in the system within 6 months. But there was very little collaboration at that time that took place between mental health, child welfare, and juvenile justice. So it kind of opened the door to doing some real system transformation in Wraparound Milwaukee, and formed the basis for what we really needed to look at in terms of measuring our fiscal outcomes and collecting that data. John, if you want to move ahead. background about the Wraparound Milwaukee. We are a system of care and a unique care management entity, as John said at the intro, serving children with serious emotional mental health needs. And as I said in my intro, we were established in 1995 to really provide community-based alternatives to youth being placed in institutional placements. Again, the juvenile correctional facilities and inpatient psychiatric hospitals. What was set up and what is unique and what helps us really measure and get a pretty good barometer on our cost data is that Wraparound Milwaukee was set up to serve all kids with serious emotional mental health needs across all the child-serving systems, including child welfare, juvenile justice, and mental health. And we're the single payer of all care for this population. So if a child goes into residential care, we pay the bill. If they go into a foster home, we pay that. If they go into a group home, we pay it. So as we talk about cost data, since we serve 100% of the, pay for out-of-home care for 100% of the juvenile justice youth that are in any one of those levels of care, and since we pay about 80% of all the placements for child welfare and all of them for SED kids, we can get a pretty good barometer of costs when we look at Wraparound Milwaukee. Again, and I'll show you that as we go to some of the things we've been looking at. Currently, we serve 1,075 youth and families. That's our daily enrollment, and about 1,600 a year total are served in the program. Funding of Wraparound Milwaukee. It's set up as a special managed care entity under the 1915A provisions of the Social Security Act, and which allows a contract to be set up to create a special managed care entity, and that contract is between the Wisconsin Medicaid program and Milwaukee County. It also forms the basis for our pooling of dollars across other systems, as I'll show you. But what we basically do is we pool money across all child-serving systems using various approaches. We get capitated payments from Medicaid. We do crisis billing on a fee-for-service basis for crisis and our optional crisis stabilization services. Now, Milwaukee County puts in the state share of that for those services. We do a case rate methodology from child welfare, which comes out of their out-of-home dollars that they used to spend on residential. And we have a fixed allocate, both a fixed allocation and a case rate payment strategy that we use with juvenile justice. So we use different strategies to pool the dollars to create a pool. But in the end, what our goal is to do is to really create one single sufficient pool of dollars, highly flexible, decategorized. So what we've gone in to do is to tear down all of those independent silos of funding that each system maintained, but that were often very inflexible and never sufficient for a population of children and their families who cross child-serving systems. So we currently pool, our current funding pool is $52 million per year. And any annual savings in excess of services paid out is retained in a risk reserve. We currently have about $5 million in our risk reserve. So one of a very key strategy was a reinvestment strategy and one way you do that, if you get Medicaid dollars through a capitated, is that those dollars really have to be used for the beneficiaries of the plan. So it's a good argument to make with your local government officials as to why you have to create a risk reserve anyway. So we get about $5 million in our risk reserve. So if we make a profit, the profit's retained, but and stays in the system. Going to the next slide. This is just a diagram and shows how we pool money across the systems. So Wraparound Milwaukee is sitting as a spaceship there in the middle, receiving the dollars through the various systems with the responsibility to manage the care for all Milwaukee children across all systems who have serious emotional and mental health needs. The reason we don't have the school system on here is that in the state of Wisconsin, we focus on the payers who pay for out-of-home care. And in Wisconsin, and there are some exceptions in other states, education does not pay for out-of-school they cannot pay for out-of-home placements. So in Wisconsin, if you're in an out-of-care facility, residential treatment center, a group home, treatment foster home, it has to be through a finding either under child welfare or juvenile justice, and those are the systems that would basically pay for out-of-home care. Medicaid is the obvious principal funder of inpatient psychiatric care and pays a portion of residential. But so we have up here these dollars that are flowing in are flowing from those entities that are responsible for paying for out-of-home care. And as we said, child welfare is through a case rate, juvenile justice is through a combination, Medicaid is through a capitated rate, which is, and 95% of our children and youth served meet Medicaid eligibility under what we call Badger Care Plus, and we can serve up to 300% of federal poverty. And so the dollars flow in, and the important thing is the dollars flow out through a child and family team, high-fidelity wraparound process, when you use that term, but facilitated by a care coordinator, family-directed team putting together a plan of care, and any services, formal services purchased out of a provider network that we coordinate and maintain. And you can see our advocacy organization, Families United, is paid out of the dollars that flow from all the systems through a straight, actually in our system, through a straight contract. Moving on to the next page, and this is going to figure in, and we'll start getting into some of the data then, is that when we created Wraparound, how do you get $52 million, or how do you get the systems to put dollars in? One way is certainly by showing good outcomes, but what we had to do is really figure out how to create incentives for the systems. And one way, for instance, for child welfare was if child welfare was going to pay a case rate into Wraparound, and that current rate is $131 a day, which is, if they were paying for straight residential, I'll show you, it would be around $300. But we had to give them an alternative to out-of-home care to get better outcomes and reduce their costs for youth that they were placing in residential treatment. For Medicaid on the right side, they wanted an alternative to inpatient psychiatric care for children, which was a fast-growing part of their budget. So they were looking for somebody who could come in and reduce the cost of that care. Juvenile justice was looking for both an alternative to residential treatment care for youth that were adjudicated delinquent that they were responsible to pay for, and also to reduce the placement in state juvenile correctional facilities of juvenile justice youth with serious emotional and mental health needs. And we do work with the school system, and in return for a lot of in-kind contributions from them, look to reduce alternative program school costs, day treatment programs, and other alternative school placements. So going on to the next slide, that gives you a little bit on the win-win scenario. Now, a philosophical and treatment approach, we utilize a wraparound approach. We won't spend a lot of time talking about that. Care coordinators facilitate the care planning teams. Families have access to family advocates. We use family advocates and educational advocates through Families United of Milwaukee. Our ratios, in case you want to know what they are, is 1 to 8. So 1 care coordinator per 8 families. So we keep it at a very good ratio, low ratio. Care coordinators have very unique legal roles in Wraparound Milwaukee, which is a little unusual. So we prepare reports, we testify in court, we prepare legal documents, and actually Wraparound participation in the Wraparound program for youth adjudicated delinquent or children in need of protection or services is actually made part of the court order. Now, not every child who's in Wraparound is under specifically a court order, but about 2/3 of our children who come through child welfare and juvenile justice who have a court order because they're in those systems. In addition, participation in Wraparound Milwaukee is written on the order. So the order will say, we find this child delinquent, rules of supervision are. In addition, care and treatment services, including placement in a residential treatment center, group home, foster home to be arranged or provided by Wraparound Milwaukee. So it's a very, we call it a flex order, but it's over time given us made it has been very helpful in terms of running the system of care and the credibility and of Wraparound, and for the judges to want to put Wraparound as a legal party in the court has been a tremendous for us in the expansion of Wraparound. So going to the next page, let's start with some cost effectiveness. So knowing a little bit about Wraparound Milwaukee now, since we can say all Wraparound Milwaukee serves all children and youth with serious emotional needs, and considering that that children who go into out-of-home residential group care will come through Wraparound Milwaukee, we can really show with a definite amount of confidence that when we show cost comparisons of Wraparound Milwaukee to group homes, correctional facilities, and residential treatment centers, we're not comparing the apples to oranges, or that, well, you're talking about kids in your Wraparound system, they're not the same kids that get placed. No, they are, because if they go in, we place them. So the average cost over the last 6 years, the average cost to be in Wraparound Milwaukee has been $3,545 per child. That's a per month, as composed to the average for a child in an 8-bed group home is almost $6,000, in a correctional facility well over $8,000 a month, in a a residential treatment center over $9,000 a month, or in a 30-day psychiatric hospital stay in Milwaukee, $38,130. So one of our first comparisons, and we do this in all our meetings, I'm going to at the end talk a little bit about how we share data, but we begin our partnership councils, our meetings with our stakeholders every 2 months by going through this, what is our per child per month cost. So we're always looking where we are. So we can say with a great amount of certainty that Wraparound Milwaukee can operate with at a lower cost. It's less than placement in an out-of-home facility, group home, correctional, residential, or psychiatric hospital. Going to the next slide, this just shows what I just said over a 6-year, this is the last 6 years, takes us through 2013. And one of the things that's really interesting also is that actually the costs in Wraparound have gone down as our population has gone up. So as we enroll more and more children and families, we're actually where we were in 2008 at $3,878 per month. Last year we finished at $3,263 per month. So while everything else is increasing, all the institutional placements, Wraparound has actually decreased in cost per child per month. So this has been a powerful thing. It's powerful to our stakeholders. It's powerful to our county board supervisors, to our county executive. These are important data that they do look at. Going to the next slide. The reduction in utilization was designed, as we said, to provide alternatives to residential, and focusing on residential treatment. And in 1995, the first year of Wraparound Milwaukee, our number of youth in residential treatment when we started was 375 on any given day. There were 375 youth on average in residential treatment centers placed by either child welfare or juvenile justice. That was 100% of all the placements of Milwaukee County youth. So we used a strategy to enroll all youth in RTCs, and those identified at risk for residential treatment, gave ourselves a 2-year period of time. So every month we enrolled some of that 375 and some of the other, and those at risk youth, and began to assume that entire population. Going to the next slide. After we finished, and where we are today is that today the average number of youth in residential treatment is 110 youth, and the reduction in average stay went from 14 months to 4 months. So when I say we pay for residential, we do, and this is, we do use residential to stabilize children. It's an important important alternative for us. We use it for crisis. We have residential centers that do care coordination, that provide many different services to us. But what we're using is a lot less residential. We use it for a shorter period of time for fewer kids. So we continue now to pay for and manage nearly all the residential treatment placements. The very few we don't in the child welfare system would be medically impaired or highly developmentally disabled and medically impaired. So we don't really deal, those would be the only kids that would not be counted here. As we show, so we continue to monitor utilization, and as the graph shows on the next, over the past 4 years, we continue to look and see a downward trend on the utilization of residential treatment services. So, and the percent of total wraparound payments that we've made per month for that, the percentage of enrollees receiving that service continues, to decline. So, in the bottom left is our cost per child per month, which we monitor very closely because of our managed care, experience background. We function as a managed care entity, so we very closely look at what is that costing per month and managing that closely. So going to the next slide, what is contributing to the lower number? We believe it's building a really comprehensive array of community-based alternatives through a provider network, having more options available that families can look at, the courts can look at, and having in-home treatment, crisis stabilizers, professional foster homes, mentors, tutors, the whole range of 70 different services that Wraparound offers has made a difference. Very well trained, very well supervised care coordinators who are very well trained in the Wraparound philosophy. The prior authorization of residential care and required monthly progress reports makes, we put a lot of emphasis on authorizing care for 30 days at a time in residential and then looking very closely at progress. So usually we get weekly progress reports. Specialized wraparound coaches who help teams with very complex youth when teams get somewhat stuck with developing effective plans, improve transitional planning with the residential treatment centers, and our highest risk kids get a specialized, more comprehensive review, including with a psychologist that specializes in those more high-risk kids, particularly the juvenile sex offenders. So going to the next slide. So we talked about the cost. We talked about the reduction in residential placements from that 375 to 110. We compared some costs. Another thing we've looked at, and our county board, we presented this to our county board, was how do you do something? What was the cost of doing nothing? So if we had continued down the road of placing so many kids in residential treatment and without having a wraparound alternative, how do we measure what that might have looked like? So we developed a methodology, and I'm going to show it on the following graph. I have a better graph that I could have used. I didn't use it, but I'll explain here. Which shows what we did is we went 5 years prior to the start of Wraparound, and we looked at what was the cost, what was the increase in number of children being placed in residential treatment placements each year, which was 5% each year. It happened that the cost of residential, the rates themselves went up 5% every year. So we looked at that and we said, well, let's use that and project forward. So we took by graph, we projected a 5% increase each year, and there's no finite way of doing this, but this has, I think, worked well for our stakeholders. But the graph, what we looked at is a 5% increase in the rate of residential, a 5% increase each year in the cost of the residential care. By doing that, and I'll show you on the next page, that when we project that out, starting in 1996 when we started Wraparound, 1995, that without Wraparound, Milwaukee would today, using that formula, be at approximately $88.8 million for the cost of just residential treatment. That's for all Milwaukee kids placed through either the child welfare system or the juvenile justice system, and that sum is 100% because they're the only two systems that can place and pay for that care until Wraparound Milwaukee entered the picture. So that's versus how much did Wraparound Milwaukee pay last year for residential treatment. We paid out $12.5 million. So the liability to child welfare and juvenile justice in 2013 for kids with serious emotional and mental health needs was $12.5 million versus a projected $88.8 million. And John, if you go to the next slide, and basically the top graph just shows that you got to look at each year a 5% growth in residential, and then where you are, because each year the number of kids would be going up. And then the bottom right just is a way we used starting in 1996, which is the $18.4 million. That was the real cost of residential treatment in 1996, when the actual cost of a residential treatment placement was $4,450. So every year we projected on the bottom where that cost at a 5% increase. We get to 2013, and that 9672 is the actual state-approved rate for residential. So that is the maximum rate for residential. That is the figure used to calculate the cost of residential treatment in the state of Wisconsin. So using that 9672 times the 2013, where we could have been in number of youth in placement, that's where we come up with the $88.8 million. Compared to what we paid out is $12.5 million. If you compare the $12.5 million to 1996, when child welfare paid and juvenile justice alone paid out $18.4 million, we're $6 million under what we paid out for that care in 1996, even though the rates for residential have more than doubled since that time. So it's an interesting way to demonstrate that, and we can project that. We can project that for a total cost, and it's a way of projecting it out. And people that think that things end because, well, our residential numbers are down, so how do we prove cost savings, is that you project forward is that, that costs still go up every year. So there are ways to do this kind of projection. Going on to the next one, I want to leave enough time to, reduction in juvenile recidivism, very important to us. And we're going to talk a little bit about recidivism, and then we're going to translate that to a cost. Nearly 45% of the youth with serious emotional mental needs enrolled in Wraparound Milwaukee are adjudicated delinquents. It's about 450 children and adolescents. Nearly 45% of the youth on probation supervision in Milwaukee County are enrolled in Wraparound Milwaukee. So Wraparound Milwaukee and our judicial and delinquency system view the collection of recidivism data as an important accountability measure and an outcome that has financial and program importance. As we go to the next slide, we recently, the Public Policy Forum of 2 years ago, conducted a study of all delinquent youth in Milwaukee County based on arrest data and established an overall 41.1% recidivism rate for youth in the delinquency system. There is no national delinquency measure, so we're only comparing to ourselves. But as the slide on the following shows, the overall rate of recidivism of Wraparound Milwaukee youth is 21%, and that's 2 years based on 1,309 delinquent youth served by Wraparound Milwaukee. So what we are showing is a lower recidivism rate than the recidivism rate overall for all delinquent youth in Milwaukee County. So this gives the system some degree of confidence, and that was in part why Wraparound serves so many children from the delinquency system. So going to the next slide, this is just a representation of that 21%. And if we go to the next slide, which is some of our highest risk kids, is that it's even lower. That would be our juvenile sex offender population at 5.6%. So even a lower rate of recidivism. So kind of moving on from recidivism to, we also, reduction in recidivism rates for juvenile offenders has resulted in a reduction in the need for juvenile correctional placements. and the county costs for such placements. And we needed a way, to show that. What's the direct impact of the reduction in recidivism? And interesting, in Wisconsin, including Milwaukee County, counties are responsible to pay for the costs of youth committed to the state correctional system, called the Youth AIDS Program. So while counties receive some base level state funding, placement costs in excess of state funding are absorbed by the county. So if you spend more than what the state gave you in youth AIDS funds, then you have to put in the difference. For many years, Milwaukee County was putting in additional dollars. So it was costing them more than what we were getting. Now, counties can retain savings in excess of their base level funding to fund community-based care for delinquent youth or other purposes if they can reduce juvenile correctional placements. So going on to the next slide, since Wraparound Milwaukee, this 60 should be about 50%, 45 to 50% of the youth on supervision are in Wraparound. When we look today at the annual level, base level funding that the state gives Milwaukee County to fund all juvenile correctional care, aftercare, correctional placements, it's $23.8 million. Going to the next slide, and I know this is a lot, and on the graph as the following shows, is that over time, the number of placements, since we've really focused on the juvenile justice population, and we get a substantial number, most youth with who are at the highest risk for placement in juvenile correctional come to Wraparound Milwaukee for enrollment, has decreased from 250 in 2007 to 142 in 2012. That's led to a reduction in state correctional costs to Milwaukee County from $23.6 to $14.9 million. This is mainly seen by our judges as a direct impact of Wraparound Milwaukee's effectiveness. So the saved monies then are used, can be surplus. The saved monies then can continue to fund our delinquency and court services to help fund their contribution of monies to Wraparound Milwaukee. So by reducing delinquency, they have more dollars to shift to Wraparound Milwaukee, and in addition, can pay for many more of their own community-based and the expansion of their own community-based system. So they've accomplished two things through doing that. Going to the next slide, which is just showing threefold. It shows the cost per year of state correctional placements just to Milwaukee County and how over that period of time that has gone down. The per daily rate that Department of Correction charges today is $289 a day. That's what we pay for, Milwaukee County pays. And then on the right just shows the drop in average monthly number of youth in the state correction system. So as we bring that number down through the system of care, through Wraparound, the Milwaukee County saves a great deal of dollars. So it was a way to demonstrate. You may not all be able to do this, but it's a focus on why should we work with delinquent youth, is that Wraparound, one of the most successful populations we've worked with are youth in the juvenile justice system. It can be a really good focal point, but we can demonstrate that we can get good outcomes and we can reduce costs through doing that. As we go to the next slide, John, what are some additional, these are more programmatic, but really the latest research has shown that youth in state correctional placements have higher recidivism rates than youth treated in the community. Youth recidivism rates within states are often reported 50% or higher for incarcerated youth. There's a financial cost you can calculate two further. I just showed you one, which was the reduction in state correctional commitment costs. But youth incarcerated in state juvenile facilities do not develop social skills such as self-control, conflict resolution, as well as those that remain in the community. They're much higher prone to mental health issues and higher rates of suicide. And grouping youth in state correctional facilities reduce their educational and vocational outcomes, disrupt families, introduce them to delinquent peers, and expose them to the likelihood of trauma. So there are additional programmatic reasons. It's not just about the dollars and about the fiscal savings, but there are many programmatic arguments for reducing youth going into state correctional care who have serious emotional mental health needs. and who it's estimated are anywhere between 75 to 80% of all youth that are incarcerated in state juvenile facilities are usually deemed to have a serious emotional or mental health need. Moving on, John, we've talked about residential treatment and how to calculate and show savings in residential to our stakeholders. We've talked about juvenile correctional placements. From a Medicaid perspective, they have been concerned about inpatient psychiatric hospitalization. And that utilization remains low for Wraparound Milwaukee enrollees. We began Wraparound, we had 5,000 inpatient psychiatric days. And last year we were under 500 days. But because we are a special managed care entity, we pay for the cost of inpatient psychiatric hospitalization for all SED kids. So when I talk about our nearly 1,075 kids, children, adolescents we serve each day, or we talk about it 1,600 members a year, those are all children we're responsible to pay for any inpatient psychiatric care. When Medicaid approved our contract in '96, it was their desire to see better management of and a reduction in the utilization of inpatient psychiatric care days. So we have set up measures to really look at the utilization of inpatient psychiatric care and particularly use our, what has worked particularly well for us is our use of mobile crisis services as our gatekeeper. But the graph on the following page really shows the utilization of per client per month of inpatient services, shows all services, but including psychiatric hospitalization. But the $51.13 per client per month, that's what we spend for inpatient psychiatric care, has remained very low. In fact, it was only 2% of the total average expenditures per member per month of the $3,200 per month in 2012. So that means out of that care for that, we are only spending $51 on psychiatric inpatient care. If we go to the next slide, you can see what we spend for all of the various services. And we keep, through the use of our mobile crisis services, crisis stabilizers, our wraparound system of care, we've been able to keep inpatient hospital care very, very low. When we started Wraparound Milwaukee, we had 5,000 inpatient psych days. Now we are at, as I was saying, under 500 days a year. And our average inpatient psychiatric stay is only 2.2 days. So we've really been able to reduce that through the array of services. So this gives you how we monitor the utilization of all care in our program. Going to the next slide, but percent of wraparound, the graph on the following slide shows that percentage of Wraparound Milwaukee expenditures on psychiatric inpatient hospitalization over the past 10 years. From 2003 to 13, we took a 10-year period of time to look at this, shows that the expenditures in no one year exceeded more than 2.3% of the expenditures, and averages about 1.5% of all behavioral health spending has been for inpatient psychiatric care. So this has been one of the single biggest arguments to the state Medicaid agency about the effectiveness of Wraparound Milwaukee has been its ability to reduce inpatient psychiatric care. So accounting for this low rate of inpatient care has been really an effectiveness of our mobile teams and availability of crisis stabilization services. So accounting, and this shows that how that's looked over the last few years, which is, it just shows that, and basically it shows that going from a little under 1%, but it shows that it has not exceeded 2.3%. So over the last 10 years, that shows how much we have paid out for psychiatric inpatient care. So from a Wisconsin Medicaid standpoint, who wanted to see a reduction in inpatient psychiatric care usage for children and adolescents, better management, we've been able to demonstrate that over time. So going to the next page, and going through this quickly, how do we disseminate fiscal and programmatic data? Is through, we do annual reports. How do we get all our data out? We do an annual report on Wraparound that goes to the county board, that goes to the county executive, goes to our stakeholders. We do semi-annual and annual quality assurance reports. We do monthly newsletters. We do a utilization review reports that we send to our stakeholders. Meetings of our Wraparound Milwaukee Partnership Council and other stakeholder meetings. And the preparation and dissemination of periodic studies and reports. For instance, the recidivism report was prepared recently for all of the judges, so it looked at recidivism. And we share our fiscal reports with the judges also. So it's no good to just collect the data. Obviously, you've got to disseminate it and make sure that it is out there for your stakeholders really to see. So these are ways that we do it. My advice is to find ways to get this. Once you collect the data, make sure you disseminate it and get it out to those folks who are your stakeholders. My final slide, and we'll open it to questions, is it's really critical to develop good approaches to measure, monitor, and report on fiscal outcomes for Wraparound programs. I think the single biggest problem to sustain Wraparound programs has been the lack of good fiscal data, and some of that, the survey really, a survey that began this, that Janet had, showed very much, and John, that it is an issue for system secure to figure out how to collect that data, but collecting it and finding ways to present that data to show the fiscal effectiveness can be the single biggest argument to sustain and expand and build your system of care. So that's quickly going through some of the ways we've done it in Wraparound Milwaukee, and we'll open it to questions.
Well, again, thank you, Bruce. I think through Bruce's comments and also through a little bit of exposure to those earlier studies, we were able to get a sense of the different ways that different communities and different evaluation efforts have tried to get a handle on that cost data, which can be tricky. But I think, as Bruce mentioned, looking at the different strategies and picking the one that might be the simplest, even if it's not definitive or final or absolutely conclusive, is powerful, as Bruce mentioned. And I think if you are able, and certainly another kind of attractive feature of the information that Bruce presented was, taking a look at that cost data from all those different angles, sort of the accumulation of evidence being extremely persuasive, and perhaps different elements of that persuasive to different stakeholders, but presenting a very convincing picture overall. So we're going to go ahead to the questions. I just did want to mention, John, can you just give out a preview of the future webinars that we're going to be having in this series, and then we'll turn right to your questions.
Sure. Upcoming, we're still settling the date for this one, but in May we will have a talk on juvenile sex offenders and wraparound programs. On June 17th, we'll be having our office hours, so you can call in and get all your wraparound questions answered from the experts. And then on September 16th, we have a webinar about the operational components of intensive care coordination using wraparound for youth with complex needs, a profile of state and local examples. So stay tuned.
Okay, thanks for that. So we have several questions here. I did just want to remind folks we are not using that raise your hand function, so if you tried raising your hand, it's not going to work. The way to do it is to chat your questions into the little question box on your control panel. So here we have a bunch of questions. I think at least some of these have been answered. One quick question, do families have a choice about participation in Wraparound Milwaukee?
Yeah, Wraparound Milwaukee remains a voluntary program, and you can stay in your own, from a managed care, thinking from a Medicaid perspective, your child can stay in their own, with their own health care coverage, and probably a twofold way I have to answer this. So your behavioral health coverage, you can stay in your own HMO or fee-for-service. That seldom happens because the Wraparound Milwaukee benefit is much higher than what your benefit is in very few systems can offer a $1,923 benefit to do that. So one argument is people, seldom want to opt out of Wraparound Milwaukee. For those that youth that come through that are involved in a court order, if the family doesn't want to participate, we can go back to court and ask for that court order to be revised. So we can do that. So kind of both are functioning. So there is some degree of family ability to opt out of Wraparound.
Okay, how about another, this is a pretty quick question, I think. What is the average length of stay in Wraparound Milwaukee and the state programs that were highlighted?
Okay, the average stay in Wraparound Milwaukee is 18 months, so a year and a half in Wraparound. The average stay in a residential treatment center when we began Wraparound was 14 months. The average stay in juvenile correctional facility is 2.5 years. And that may be less now. It was 2.5 years, and that would include their aftercare. So the psychiatric hospital stay, the average overall, we see very few 30-day stays. So the average stay for non-RAP kids is I think about 7.5 days. That's the average inpatient stay in Milwaukee County. So it's about 2 for RAP kids.
So I guess a little bit of a follow-up to that. Do you ever get the argument that, well, all across the board there's less reliance on these sort of deep-end placements, so maybe there's some kind of desire to cut contributions to Wraparound Milwaukee or anything along those lines?
Well, we've made that as part of the system, is that for the other child-serving systems, their contributions to Wraparound have not gone up. So what we agreed to do early on was to say, we don't want, how can I say this, child welfare and juvenile justice were saying, if we go back to 1996, they were putting about $18.5 million into the system, just residential and residential treatment care for delinquents and child welfare kids. So today, their contributions are almost the same as they were back in 1996. So one of the things we are with those systems has been they didn't want to, increase the amount of dollars because of the fact that there are fewer dollars available today than there were back then. Dollars are scarcer. Contributions from states, child welfare and juvenile justice are less. So we argued that the reinvestment of the dollars is that it's not going to cost you more, and you're going to serve more children with those dollars. So if you really think from going back, that 375 youth that were served for $18.4 million, the child welfare and juvenile justice investment today is around $20 million, but there's 1,075 kids in the system being served. So our argument was keep the dollars, you can serve more kids at less cost through Wraparound. So that's the argument we made to invest more dollars in the system. And show outcomes, and we talk principally cost outcomes, but you also are showing clinical outcomes. Systems want to invest their dollars in that. So that's been the argument to reinvest the dollars. And Medicaid has taken kind of a hold harmless. Is they look every year at the rate. They do an actuarial analysis of the rate. So they're pretty independent in creating that rate each year for Wraparound Milwaukee. So it's been designed so that every system is getting the outcomes it desired, and that's why they continue to put in the dollars. So, but we maintain that effort, and I think that is an important, investing savings is important in the system.
Okay, thank you. What system does Wraparound Milwaukee use for tracking the data for families in Wraparound?
We track all of our data through our own information. We have our own IT system called Synthesis. So we're able to track all of those dollars through Synthesis, because all of our payment, it's both our electronic medical record for kids, and it links all of our agencies on one record. So we can track both fiscal and clinical outcomes through that system. And we pay, it's also our payment system. So we authorize care through Synthesis, and we pay all our vendors through Synthesis. So we, at any given, we have, very, everyday online access, real-time access to all of the data and information. So it's very helpful to utilize a good IT system to be able to track all of that, all of those data. So all our providers use that system. So that allows us to track our costs very, very easily. So we can tell you on any given day actually what our per child per month costs are and what our utilization of any service is, since we're paying all of the dollars out in the in the system. So it's all done on one electronic health record, and even our juvenile justice, they're on our Synthesis system. So our delinquency and court services uses our system also. So Synthesis. So that's helped dramatically in doing all of the tracking of costs.
And how do you determine what is billed to Medicaid versus what is the fiscal responsibility of juvenile justice or child protection funding sources?
Well, the way it works in our system is Medicaid, okay, we pool dollars, but each one is determining somewhat separately. So Medicaid is saying we're going to give you X amount of money each year based on based on an actuarial study. So it's $1,923 per month per child. What they say is that includes all behavioral health services. Behavioral health meaning individual therapy, in-home therapy, medication management, substance abuse services, anything that Medicaid pays for on a behavioral health that's in the state Medicaid plan or is an EPSDT service. For residential treatment and treatment therapeutic foster care, the state Medicaid does a percentage. It's 52.3% of the costs are deemed Medicaid costs because Medicaid doesn't pay for room and board costs. So, so all of that then is figured into their rate. Child welfare then figures their rate is based on other dollars for Medicaid covered services. So, and it's a percentage that was determined over time. So that is how that was determined. So the juvenile justice dollars come two ways, and they come through us through either a case rate, which is the alternative for kids that would otherwise go, well, let's do the first piece. They do an $8 million, which is what juvenile justice paid out their base level funding in 1996 for delinquent youth in residential treatment. They've kept it at $8 million. Then we get a case rate, which is a percentage of what they would, $3,500 a month per child for a specialized program we provide as an alternative to state correctional care. So we figured out a way to do that. That's about 40% of what they would have to pay, 35% for kids going into that are committed to state correctional care. So each one is determined somewhat separately for each one, but then the dollars are pooled together. And so we've kind of broken that apart and in terms of the contributions. But when it comes together as one funding pool. And if I had more time, I would go into all the ins and outs of how we calculated all of these rates over time and what formulas and things that we do use. But that's basically, each one is determined a little bit differently.
All right, I'd say we have time for maybe 2 more questions. We don't want to burn Bruce out here too much, but a real basic question, can you just go over what are the enrollment criteria, and are you limited to only serving children with Medicaid or the juvenile justice child welfare population?
No, we can serve out of our, we serve basically, the criteria is the same for all kids. So it's a child with a DSM-5 diagnosis. It's a child that's has a functional impairment due to that mental health condition at home, school, or in the community. 3, it's a child who's involved in at least 2 or more child-serving systems. They've touched 2 systems, and those are either child welfare, juvenile justice, special education, or mental health. So they have to have touched that. They don't have to have been under a court order. And the final one is that there has to be some risk, imminent risk of placement out of home without the services of wraparound and a higher level of care. So those are the general conditions you have to meet. We have 370 voluntary, by that I mean families that have no contact, they're not involved in the court system. However, all of those, 95% of our, do meet Medicaid eligibility and under our Badger Care Plus program. So we do have a high rate. So it's about only about 5% of our youth do not meet Medicaid eligibility. And Wisconsin has an expanded under Badger Care Plus, which other states, some of them do, that we can serve children who are eligible, Medicaid eligible, and their families up to 300% of federal poverty. So that's under the Badger Care Plus. So we have a little bit more leeway in terms of serving that. But it's about 95% Medicaid eligibility. But we have some that aren't Medicaid eligible.
Okay, and then finally, I think this is probably a logical place to end. Have you ever studied outcomes for youth after they leave Wraparound Milwaukee? We know you showed some information about recidivism there, but what about their future use of residential or inpatient psychiatric? Any information on that?
Yeah, I mean, we're following, we did do some 2-year outcome studies of kids that, you know, what we've been trying to do is kind of follow them into adulthood. And we're now an HTI, so we have an adult program, and maybe it will get easier. But one of the problems we had is just tracking youth to find out where they were, you know, 2, 3, and 4 years after they leave Wraparound. It's amazingly difficult to track them. And so we are looking at longer term. The one we have done is recidivism, because that is 2 years post. That's a 2-year, includes both kids enrolled and kids that are disenrolled. So that's now going out 2 years, and we'll go out further over time on our recidivism studies. So we're looking at more ways to really capture that, and we'll hopefully do that in the future.
All right, well, with that, again, I want to thank you, Bruce, for being on our webinar today. I want to thank everyone who was out there in the audience. Just a quick reminder, within a couple hours, we should have the webinar recording as well as the slides alone. You can download those as a PDF. Available on the NWI website. You can see the URL up there, and that'll all be up really soon. Again, we look forward to the future webinars. Information on that can also be found on the NWI website. So I hope everybody has a really great rest of the day and rest of the week, and we're signing off now. Bye-bye.
Thanks, Janet. Bye-bye.